Welcome to this video on nasal intermittent positive pressure ventilation, or NIPPV. This series focuses on its clinical application, from mechanisms to bedside use, including indications, synchronization, and real-life scenarios. This topic presented by me, Dr. Salem Keshba. In our first case, we look at a 25 and 5/7 weeks preterm infant. Initially, the infant required T-piece ventilation and was moved to CPAP, then NIPPV. Despite the settings, respiratory distress worsened over the first hour, with a rising FiO2 requirement. The initial blood gas showed significant respiratory and metabolic acidosis, and the chest X-ray revealed complete opacification, suggesting severe RDS. This highlights that for severe RDS, you should consider surfactant replacement rather than just escalating NIPPV settings. Following the Ensure approach, the infant was intubated and given surfactant. By 10 hours of life, the infant was successfully returned to NIPPV, and by day 2, the clinical picture had improved, allowing for weaning of pressure support. This case illustrates that abdominal distension, or CPAP belly, is a common complication. Key takeaways include the importance of early surfactant therapy and the use of an orogastric tube to mitigate the risk of air leaks into the GI tract. Our second case involves a 24 and 2/7 weeks preterm infant. After receiving surfactant on a conventional ventilator, the infant was extubated at 8 hours of life directly to secondary mode NIPPV with moderate settings. The infant later experienced worsening apneic spells and was found to have a coagulase-negative staphylococcus infection. This teaches us that if NIPPV seems to fail, you must investigate for systemic illnesses like sepsis as a possible cause. NIPPV provides an intermediate approach in the spectrum of respiratory support, sitting between non-invasive CPAP and invasive mechanical ventilation. It is increasingly popular due to its potential to reduce BPD by minimizing barotrauma. Historically, NIPPV has evolved significantly. After falling out of favor in the 1980s due to concerns over GI perforation, randomized trials in the 2000s renewed interest, and today we utilize advanced synchronized modes like SNIPPV and NIV-NAVA. Physiologically, NIPPV works by washing out nasopharyngeal dead space and recruiting collapsed alveoli to establish functional residual capacity, increased intermittent distending pressure above PEEP, increased flow delivery in the upper airway. This reduces the work of breathing and improves overall pulmonary mechanics. It is important to distinguish between the two modes. Primary mode is used soon after birth, while secondary mode is used after extubation from invasive ventilation as a weaning strategy. While sometimes confused, NIPPV and BIPAP are not interchangeable. Research suggests that BIPAP may be associated with higher morbidity compared to SNIPPV, so these modalities should not be considered equivalent without more evidence. For RDS, evidence supports early NIPPV over CPAP alone. Additionally, clinicians should consider early surfactant therapy for infants with severe RDS to prevent the need for more invasive interventions. Preventing BPD is a primary goal. Since invasive ventilation contributes to lung injury, aggressive weaning and timely extubation to non-invasive modes within the first 72 hours are associated with better outcomes. Finally, we must recognize the risk factors for NIPPV failure, such as frequent apnea. Factors like male gender, higher gestational age, and increasing FiO2 requirements in the first few hours post-extubation can indicate a higher risk of failure. Let's discuss synchronization. Synchronized NIPPV, or SNIPPV, aims to align ventilatory support with a patient's own efforts. While historical methods like the Grace-B capsule are now obsolete in the U.S., newer techniques like flow triggering and neurally adjusted ventilatory assist, or NIV-NAVA, continue to be explored to reduce asynchrony and improve patient outcomes. When considering NIPPV, it's essential to understand the clinical context. It is indicated for infants with impending ventilatory failure or as a weaning strategy. However, be aware of contraindications like upper airway abnormalities or cardiovascular instability, and watch for hazards such as nasal irritation, feeding intolerance, or potential lung injury. Proper setup is vital. Ensure you have the necessary supplies, including the ventilator, nasal prongs, and an orogastric tube. Follow a structured procedure. Size the prongs correctly, secure the interface, insert an orogastric decompression tube to aid ventilation, and initiate caffeine therapy to support the transition to non-invasive support. This table provides guidance on initial and maximum NIPPV settings. Note that parameters differ significantly depending on whether you are using the primary or secondary mode. Always verify the current mode before making any adjustments to the infant's ventilator support. Adjustments should be guided by blood gas results and clinical response. If a patient experiences desaturations, follow a stepwise escalation. Start by optimizing the seal, then adjust inspiratory time, PEEP, and PIP. Keep the maximum mean airway pressure targets in mind based on the infant's birth weight. Continuous monitoring of SpO2, heart rate, and respiratory rate is required. If NIPPV isn't sufficient, be prepared to act. Reintubation should be considered if the infant shows signs of severe apnea or if blood gas values, such as pH and CO2 levels, fall outside the acceptable clinical range. Radiographic imaging can show the efficacy of NIPPV. These images demonstrate how switching from CPAP to NIPPV can improve hazy opacification by recruiting collapsed alveoli. This clinical improvement often mirrors cases where timely support adjustments prevent the need for prolonged invasive ventilation. To summarize, NIPPV is a valuable intermediate support mode between CPAP and invasive ventilation. Always distinguish between primary and secondary modes, maintain a decompression tube to avoid abdominal distension, and monitor closely for signs of failure that warrant re-evaluation or reintubation. For deeper learning, consult the provided chapter from the Neonatal Fellowship Series. Further reading on RCT comparisons, the physiology of non-invasive support, and the management of complications like air leak syndromes will provide a comprehensive understanding of NIPPV in neonatal care.